coordinates and moderates this series with me. Today, our guest speakers are Dr. Leah Gandler, Dr. Maria Pilar Parisi, Dr. Paulo Simoni, and Dr. Sergio Viana. This session will focus on pediatrics. The speakers will present their cases, and at the end, we'll have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. And just a quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and with that, Hillary, please kick off the session.
Hi, everybody. It's my pleasure to introduce Leah Gandler, who completed her medical school training at Midwestern University Chicago College of Osteopathic Medicine in Illinois, and her internship at Harbor UCLA Medical Center in California. She did her diagnostic radiology residency training at Thomas Jefferson University Hospital in Philadelphia, where she completed a mini fellowship in musculoskeletal imaging. She completed additional clinical pediatric radiology fellowship at CHOP, the Children's Hospital of Philadelphia, as well as a pediatric musculoskeletal research fellowship at CHOP. Her areas of interest are pediatric musculoskeletal radiology, including ultrasound and musculoskeletal manifestations of metabolic disorders. Okay, Leah, take the screen.
Her microphone.
Leah, turn your microphone on.
Okay. I think
Can you share your screen?
Sure. It wasn't letting me at first, so
Part of the excitement.
I know. Okay, so let me just I have to, I think, swap. Okay, everyone see my presentation?
Perfect.
Okay, great. I'm going to be sharing with you guys a case of pediatric scurvy. My name is Leah Gandler, and thank you for that wonderful introduction. I'm so happy to be here today. So I will just go ahead and start off the case. So we have a case of a 14-year-old male, history of cerebral palsy, developmental delay, shunted hydrocephalus, kind of like a complex medical history. He presents with progressive discomfort and immobility. He was previously able to ambulate with a walker, and then he proceeded to limp. And then within the span of a month, he is no longer able to walk and complains of pain. Per his doctors, there is no concerns for infection. The neurosurgeon did obtain a CT head due to his shunted hydrocephalus. There was no change in ventricular size. There's no neurologic symptoms. So he was referred to the emergency department. In the emergency department, they worked him up for UTI, UA negative. They took some labs. The only remarkable labs was slightly elevated ESR, CRP. He was mildly hypertensive, but otherwise stable. They obtained an abdominal and pelvic x-ray, which were unremarkable. So at this point, given his inability to walk, they were concerned about osteomyelitis, and they got an MRI of the lumbar spine. which showed. So here's some representative images of the pelvic area, axial T2 non-fat sat and fat sat. And here we see the findings, bilateral iliac wing subperiosteal collections with thin septations, fluid levels, as you can see. And then from there, we obtained additional imaging in other parts of the body. You see he has a similar finding in the scapula with surrounding muscular edema. He's got edema within the costochondral junction, the rib ends, also with surrounding edema in the chest. Further imaging in the pelvis. So this was a T1 fat sat pre-contrast. You can see there's intrinsic T1 shortening within the collection, so suggesting hemorrhage. And then post-contrast, the periosteum enhanced, but the inside of the collection did not enhance. So at this point, we were pretty confident in our diagnoses that these were subperiosteal hemorrhages, and that we felt that this is pretty much characteristic of scurvy, vitamin C deficiency. And at that point, we did actually evaluate the patient within the MRI. He did not have bleeding gums, but we were able to elucidate from the mom that he eats a diet consisting almost entirely of chicken nuggets. So very nutrient deficient, and we can see why he developed this. Subsequently, he did also get an ultrasound prior to IR drainage of these collections, and you can see, the cortex of the iliac wing, the periosteum. There's no flow, and it looks beautifully with these lace-like septations. Like you put this in the ovary and it's an ovarian cyst. So it's a beautiful representation of hemorrhage. And then to discuss some of the pathophysiology behind the disease. So unlike most animals, humans lack the enzyme, the final enzyme to convert glucose into ascorbic acid. They must obtain vitamin C from the diet. And vitamin C is a cofactor in many enzymatic reactions throughout the body. So it affects multiple body systems, but it's very important as a coenzyme for collagen production in the fibroblast. So the hemorrhage is not due to any coagulation factor deficiencies. It's due to a lack of vascular integrity of the blood vessel itself, because the blood vessel is reliant upon collagen for structural stability. So if you completely eliminate vitamin C from your diet, it will produce clinical signs of deficiency in approximately 1 to 3 weeks. And initially they're very vague, especially in children, like irritability. But then they progress to, not being able to walk, such as in this case. So the MSK manifestations are same as elsewhere in the body, predominantly hemorrhages. And here's a beautiful illustration from Circulation from Libby and Akawa. It shows the production of collagen and each step along the way. And here I want to draw your attention to this step, which requires vitamin C to convert the procollagen protein and hydroxylate them, so that it can be on its way to the final strong collagen fiber. And then other manifestations, you can get joint pain, swelling, muscle pain, muscle wasting, fractures. And approximately 80% of patients have MSK symptoms. And infantile scurvy, so this is very rare, especially in developed countries. Neonatal is pretty much non-existent because the baby gets it from the breast milk or from formula if it's taking formula. So as long as the mother is not vitamin C deficient, the baby won't be. But like later on, like 12 to 15 months of age or 6 to 15 months of age, around that time, you can start to see if the diet is deficient in vitamin C. The earliest manifestations you can see are just the ground glass, like just demineralization of bone. And then you have some of these characteristic findings like the white line of Frankel, which is just the widening of the provisional zone of calcification and thickening. And you basically have the same sign around the epiphysis, the Wimberger ring sign. The tremor field zone refers to metaphyseal lucency. And that is just like basically secondary to demineralization. And you usually don't see the subperiosteal hematomas on X-ray unless they've been there for a while and have started to calcify. Okay, and then here's some examples of mimics. This is a kid with osteomyelitis with subperiosteal abscess. You can see here's the bone and the surrounding muscle, and there's this collection here. And this is in transverse and long axis. You see the humerus, and you see this collection here. It's a little bit more, you don't see the lace-like septations, but it's a little bit heterogeneous. You can see how this could be confused with hemorrhage versus abscess. And then on the MRI, T2 fat set, you can see bone marrow edema, muscle edema, and then this fluid. And then the T1 fat set, this is pre-contrast. He did not wind up receiving contrast, but you can see there's no intrinsic T1 shortening within this collection. So it probably is not a hemorrhagic collection. And then other mimics, vitamin D deficiency, mostly secondary to the metaphyseal irregularities, because vitamin C deficiency also causes metaphyseal irregularities. Child abuse also, because of the corner fracture. You can also get corner-like lesions with the lateral metaphyseal sign, and but they aren't fractures, they're infarcts actually with scurvy versus fractures with corner fracture and child abuse. You do see metaphyseal lucency with leukemia, but other findings should lead you away from leukemia, such as blood work and if all else, MRI. Pediatric syphilis also has metaphyseal findings that may potentially be confusing. And then platelet dysfunction presents similarly clinically because of the propensity to hemorrhage. Also, you can get kind of like for vitamin D, you can get rachitic rosary. And then we saw in this patient, he had the costochondral swelling and bleeding. This is called a subascorbic rosary, which is secondary to vitamin C deficiency from the hemorrhages at the ends of the ribs. So may look similar on clinical exam, but the imaging is different, and they're obviously different entities. And yeah, that's my case.
Thank you, Leah. Beautiful case. Now it's my pleasure to introduce Dr. Maria Pilar Parisi Gomez. She's from Valencia, Spain, and she studied at the University of Valencia and became a certified radiologist in Terrassa, Barcelona, subspecializing in MSK and interventional radiology in La Ribeira. In 2008, she moved to New Zealand, becoming first an educational affiliate and later a fellow of the Royal Australian and New Zealand College of Radiologists. She has worked as a consultant at Auckland Hospital since 2011. While mainly based in New Zealand, she still works remotely as an MSK radiologist for the European Musculoskeletal Institute in Valencia. She also acts as a consultant for MSK studies at the Center of Advanced MRI in Auckland, Sonel, and Mercy Radiology. The most important part of her workload is focused on MSK imaging, a field in which she lectures regularly and has published more than 60 indexed articles, 9 book chapters, and a textbook. Dr. Pilar Parisi Gomez is a member of the editorial boards of Skeletal Radiology, AJR, BMC Imaging, and the Journal of Ultrasonography, and does regular peer reviewing for several radiological publications. She's an active member of local CERME and international radiological societies and specialty subcommittees. She currently serves as chairperson of the Pediatric MSK Subcommittee of the European Society of Skeletal Radiology. And that's it. Pilar, take it away, please.
That ended up very long. Okay, let's see. I will see if I can share my screen. Great. All right. Can everyone see it?
Yes.
Well, thank you very much for the kind introduction, and it is an honor for me to join your series. So, without further ado, let's start with the case. This was a 3-year-old boy that presented with acute neck pain and torticollis after a somersault. And for those of you that are not English speakers, this is what a somersault is. And on clinical examination, there was extreme neck stiffness, and the head was fixed in maximum left rotation with some degrees of flexion, and the chin was slightly tilted to the right. So that's more or less the position of the head of this little bird, and is what is called the cock-cropping position. On X-rays at presentation, we can see an AP and a lateral X-ray were taken. The lateral X-ray, as you can see, everything is superimposed in it. So eventually it's very difficult to evaluate any structures separately. On the AP, we can see that there's a rotational deformity of that C-spine. We can actually follow the neurocentral synchondrosis to see that at the level of the axis, well, that axis with the dens almost looks like it's in a lateral projection. And the lateral masses of the atlas are actually kind of anterior and posterior to it with an increased distance. And the spinous process is a little bit lateralized, but it's eventually posterior to the dens. So these basically led us to think that there was an atlantoaxial subluxation. And the patient was sent to have a CT. CT, MR can be used as well, but CT is more immediate in these cases because obviously it's difficult to position these children on MR, and eventually they need to keep very still as well. So CT is more immediate. This is what the CT looked like, and you can see how there is a subluxation of the atlas over the axis. It is confirmed in this transverse plane, and we could see it nicely as well. We could see it nicely as well in the coronal plane that we reconstructed following the longitudinal axis of that C-spine and the axis. You can see that the lateral masses of the atlas eventually are anterior and posterior with respect to it. This was a 3D reconstruction of the volume rendering, and we can see how there is an anterior subluxation of that right facet pivoting over the left, and there's not much anterior displacement of the atlas. But this basically confirmed that there was an atlo-axial subluxation. This child had a concurrent pharyngitis and tonsillitis. Eventually, it was seen in the bloods that there was a neutrophilia, a leukocytosis with neutrophilia and elevated CRP. So the diagnosis of Grissel's syndrome was made. And Grissel's syndrome is a spontaneous atraumatic subluxation of the atlantoaxial joint following a peripharyngeal inflammation. In this case, there was minor trauma with the somersault. And this was first described by Aetius of Amida, who was Greek, born in current Turkey, in the context of diphtheria, and subsequently by several Persian doctors. One of them even suggested a treatment for it. Charles Bell also described it in the context of syphilis. But it eventually took its name from Pierre Grissel, who published the case in 1930. Most cases, this is a rare condition, most cases happen in the pediatric population, 90% of cases in patients under the age of 21, and it follows an upper airway or head and neck infection, or ear, nose, and throat surgery. And different groups describe different prevalence after these events. The clinical presentation, the initial clinical presentation is torticollis and fever. And initially there's a rotational deformity, but without subluxation. There are some distinguishing features in this torticollis that make it different from the torticollis, for example, of the congenital muscular torticollis. And it is that the sternocleidomastoid muscle that presents the spasm is the one that is ipsilateral to the tilting of the chin, as opposed to the one that would be ipsilateral to the rotational deformity. Sometimes the spinous process of the axis can be palpated away from the midline towards the affected side. And sometimes there is reduction in size of the nasopharynx as well. The atlas, as it is subluxed, generates a bit of a mass effect, and the child may have a nasal voice. And if it is not treated promptly, then subluxation may develop. The pathophysiology is currently based on a two-head hypothesis. The first head being the predisposition that occurs in children because there is pre-existing cervical ligamentous laxity. The alar ligaments are longer in the pediatric population, and also the atlas dense interval ranges up to 4.5 millimeters, which is a little bit larger than in adults. And here we've got a reminder of the anatomy. We can see the alar ligaments and how we can see them in coronal on MR, and the transverse ligament and how we can see it in the axial plane on MR. The second head of these two head hypotheses is the inflammatory head. And this happens because the pharyngovertebral veins link the posterior nasopharyngeal veins to the periodontal vascular plexus. And what happens is that through these connections, inflammatory mediators can spread and eventually cause synovial and vascular engorgement, periligamentous inflammation, and edema that increases the laxity of the transverse and the alar ligaments. For the diagnosis, to achieve the diagnosis, the clinical suspicion is really important. And we can use imaging techniques to confirm that subluxation, such as radiographs. The CT, which is actually the gold standard in these cases, it can be performed in a dynamic fashion. But I guess in our case, it wasn't necessary because there was a fixed deformity. It also gives us an idea of the severity of the subluxation through the Fielding and Hawkins classification that we will see briefly. And MRI can be used as well. But as I explained, it's probably not the first tool to use, even though there are groups that advocate this, because obviously it involves no radiation. It gives us a lot of good information about the state of the soft tissues and also the spinal cord if there is associated neurology. Obviously, with these cross-sectional techniques, we can also rule out other conditions that could eventually show subluxation as well. Treatment is based on severity, and the severity is given by the Fielding and Hawkins classification, obviously also by the neurological status. And this classification is based on the displacement of the atlas above the axis. There are 4 types of increasing severity. Type 1, no subluxation. There's a fixed rotation of C1 over C2, pivoting on the dens, and there is no significant anterior displacement. And this is the most common type. Type 2, in this case, there's a unilateral anterior atlantoaxial subluxation, and there is an anterior displacement that is a little bit more evident, in between 3 and 5 millimeters. And in this case, there's mild injury to the transverse ligament. Type 3 is more severe. There's injury to the alar ligaments and the transverse ligament as well, with bilateral anterior atlantoaxial subluxation of C1 and an anterior displacement that is more evident, more than 5 millimeters. And then Type 4, which is the more severe one, is a posterior subluxation of C1 in combination with a fractured dens or with a congenital dens aplasia. And in these cases, this is rare, but in these cases, there is neurological damage or even spontaneous death. In type 1 and type 2, the treatment is less aggressive, it can be conservative. Very important that antibiotics need to be given because that is actually the treatment of the cause, is the infection and inflammation. In type 2, cervical traction and muscle relaxants can be used. Type 3 and type 4 need a more aggressive approach with halo immobilization and even arthrodesis or cervical fusion. So our case, sorry, too quick. Our case corresponded to a type 2. So there was pivoting. That left facet was still well aligned, and there was an anterior subluxation on the right. The gap between the atlas and dens was between 3 and 5 millimeters. And on CT, we could see how the transverse ligament was a little bit stretched. The fat spaces around are still preserved, but there was continuity of the ligament, I guess. CT is not ideal for this evaluation, but the patient, meaning the evaluation of the soft tissues, but on the basis of the fact that we already had a diagnosis, we treated with immobilization, antibiotics, anti-inflammatories, and in this case also being a type 2 cervical traction and muscle relaxants to align those bones. And eventually, this was 8 days later, you can see how the alignment of the axis and atlas now is normal. You can also see how there is a lot of lymphadenopathy in that neck. In the parapharyngeal spaces, the tonsils were enlarged and still a lot of enlarged lymph nodes in the cervical triangle spaces on the sides. And we could see as well how the distance in between the atlas and dens had normalized with a sliver of fluid still in that synovial space. There was no damage to the cord. The signal of the cord is completely normal. The alar ligaments were intact, and so was the transverse ligament with only a slight increase in signal intensity because it had been stretched. These are examples from the literature in which we can see on MR how there's stretching of the transverse ligament with a partial tear and an increased distance in between the lateral mass of the atlas and the dens, and a type 3. And this was another type 2 in which the stretching of the transverse ligament is a little bit more evident. This was the child at 8 years of age, and we can see how that gap between the atlas and dens is still 4 millimeters, but it can be up to 4.5. And in the transoral view, there's a slight asymmetry, but this is important to note that this can be anatomical variation. In this case, it could also represent a little bit of residual laxity. So the take-home points from Grissel's syndrome is that, well, it's an atraumatic atlantoaxial subluxation that follows peripharyngeal inflammation. Clinically, there's torticollis in the context of fever and inflammation, and it's very important to suspect this clinically because the diagnosis is based on this clinical presentation, but also radiographs and CT, eventually MR, as we discussed. And the treatment is based on severity that is obtained by the imaging analysis, and it's very important to include antibiotics, which are the treatment of the course. Thank you very much.
I'm getting my act together, I promise. Okay. Now it's my great pleasure to introduce my good friend Paolo Simone, who graduated his medical studies at the University of Rome, La Sapienza in 2002 and completed his residency in medical imaging in Rome in 2006 at the University Hospital Campus Biomedico of Rome. he's laughing. He studied musculoskeletal imaging from 2007 to 2010 at the Clinique Universitaire, I'm butchering this, Saint-Luc in Brussels. And from 2010 to March 2015, he was the head of the musculoskeletal service at the University Hospital of Liège, where he simultaneously completed his PhD. He has been head of the pediatric imaging department at the University Children's Hospital Queen Fabiola in Brussels since June 2015 until now, with a special interest in pediatric musculoskeletal imaging. He was appointed professor of radiology in 2020 at the Université Libre de Brussels. In his spare time, he also obtained a master's degree in economics and administration from the University of Paris, one Panthéon-Sorbonne in 2017. He's a member of the International Skeletal Society, European Society of Pediatric Radiology, MSK Task Force, and delegate for Belgium to the Quality Protocol and Standards of the European Society of Radiology. He's the current chair of the ESSR Subcommittee on Pediatric MSK Imaging for a second term and chairperson of the Leadership, Quality, and Management Committee of the Belgian Society of Radiology until 2025. He's authored a lot of papers and chapters, and now we're going to enjoy his presentation.
Yes, next time I will give you the shorter version. Thank you very much. Thank you for this kind invitation, and it's an honor to present in the community. Thank you, Hilary. Thank you, Aline, for the invitation. I'll try to share my screen, and I hope you can see. Up. Okay. Is that okay?
Yes.
Perfect.
So I would like to present the case of two brothers with acrosteolysis and various skin lesion. If you want to participate in a short quiz during the presentation, you can scan this QR code. It's not obligatory, it's not mandatory, but you can. So this is the appearance of two brothers who were asymptomatic at the birth and started to complain from progressive hypertrophy of the gums, and from the appearance of various masses, the fingers, the two, but also at the level of the face and the scalp. This is the appearance of the younger brother at 9 years with the evident deformity of these fingers, especially at the distal part. Because we are musculoskeletal radiologists, we are interested in the soft tissue, so I'll present here the images of the head examination with this masses of the soft tissue, T1 hypointense with with contrast enhancement, which is very heterogeneous. Heterogeneous is also the two weighted images, and the ADC examination showed that it's probably an hypocellular mass. This is more musculoskeletal. It's the images of the two brothers. On the left, the older brothers, on the right, the younger brothers, with acrosteolysis, diffuse of several fingers, and bulky masses of the soft tissues. This is the macroscopic specimen of the masses of the chin of the younger brother, and this is the histology. And there's this eye-line background with round and spindle cells with blunt nuclei, and the pus test positive. So here, if you want just few seconds to participate, because I was very challenged by this case, so you can vote if you wish. I'll take just a couple of minutes, a couple of seconds. Nobody want to vote, so I'll give you the diagnosis: a very rare disease with a juvenile eye-line fibromatosis. As you know, is something that was described a long time ago from Murray in 1873. Is an inheritance, is also autosomal recessive transmission. Is rare. One out of 1 million individuals. And there's a gene with different variants which have been localized on the chromosome 4, And there's a spectrum of the expression of this disease from the young age to the intermediate age with different severity and possible involvement of the organ like liver and spleen. But the question is, why do I present as such a strange case and very rare case? The question is that I wasn't comfortable when I started to report pediatric musculoskeletal imaging with the TURF, because the TURF, even in a normal patient, can be very different from the appearance we are used to see in adults. This is a case of the normal children coming for a trauma. There's no trauma, and we could be not comfortable with this shape of the TURF. Basically, to be short, when there's a lost bone at the distal part of the TURF, what entering the differential diagnosis is ischemic sclerosis, ischemia, trauma, tumors, infection, hyperparathyroidism, sometimes neurological disorders, and as in your case, genetic condition. And when the loss of bone is isolated, we must think to tumors or infection, and obviously also trauma, ischemia. When the bone loss is localized more proximally, we are even facing an extensive osteolysis or accepted arthritis, or more commonly to the GIA. This is a case of a systemic sclerosis with multiple sites of acrosteolysis, and you can see here that different from the adults, there's no calcification, so the diagnosis can be not so obvious in the early stage. This is what probably is more characteristic, is hyperparathyroidism with bone loss, superior osteal resorption, and some lytic images corresponding to brown tumors. This is another condition which is more rare, is a primary hyperostotic osteoarthritis with concurrent osteolysis and periosteal apposition. You can also have in children the secondary form in chronic severe condition like cystic fibrosis, for example. This is what probably is more common to see in the daily practice, is the GIA, the psoriatic variant. And as you can see here, the bone loss is centered on the articulation, but you can see that here the first impression is to be faced to an acrosteolysis. In case of infection, you can also have this kind of appearance, and we have also the impression to have a nidus or an osteomastoid. And I posted here the OCAD community, and I must say that Hillary was the only one who was right, because it was infection and not an osteoma or glomus tumor. This is the appearance with this infection that can occur in children also, so distally. And there's an images that can be very similar to a glomus tumor or osteoma osteoid. This is the X. So the important in this case, in my view, was that the acrosteolysis in children can encompass a very large spectrum of diseases, and can be the bell to giving us the signal or the clue to find a systemic condition, a severe condition or a genetic condition, but also more typical condition like psoriatic arthritis. So the take-home message is the acrosteolytis is found in a large spectrum of disease with children. This ischemic sclerosis and hyperparathyroidism are a frequent cause of bone distal loss, but we must point out that the systemic sclerosis in children, we have no calcification in most of the cases. In psoriatic variant of the GIA, the bone loss is more proximally centered. And in isolated acrosteolysis, tumor and infection must consider in the differential diagnosis, especially when there's isolated bone loss. And in the case in which this acrosteolysis is diffuse, you have also rule out the rare genetic condition. Thank you very much.
Thank you, Paulo. Beautiful case.
Yeah, thank you, Paulo. I have never seen any case like this. Anyways, okay. Let me just find here my next, okay. Yes, and of course, it's my pleasure to introduce my dear friend, Dr. Sergio Viana. He's a practicing musculoskeletal radiologist at Tesla Diagnóstico por Imagem, Diagnóstico Imagens Médicas, and the Children's Hospital of Brasília, which is the capital of Brazil. And he's also a member of the International Skeletal Society and the Brazilian College of Radiology. He graduated with a degree in medicine from the Universidade Federal do Piauí, and completed residencies in internal medicine at the Universidade Federal de Pernambuco and in radiology at the Hospital de Base do Distrito Federal. He co-authored the book chapters, and several articles on MSK imaging, and has lectured on this subject as a guest speaker for more than 20 years, being actively involved with continued medical education in his platform, which is called Advanced MSK. Please, Sergio, share your screen.
Let me try to just a second. Can you see my screen?
Yes.
Okay. Well, good morning, good afternoon, good evening, wherever you are. First of all, thank you, Aline, and thank you, Hillary, for having me once again. It is always a great pleasure to join this awesome case presentation series. Leah, Pilar, Paulo, congratulations on the beautiful presentations. And now it's a big responsibility and a lot of pressure on me, but that's the way it is. So today I'm gonna present the case of an 11-year-old boy with pain in his left shoulder for a month. There was a report of a lytic lesion in the left scapula, but these x-rays were never presented to me. He was in good general condition. His past medical history was irrelevant, and he had normal laboratory tests. 2 biopsies were carried out, which revealed reparative bone changes and the absence of neoplasia, and a 3rd biopsy was being considered. There was progressive resolution of pain over a month with non-steroidal anti-inflammatory drugs alone. And finally, after all this investigation, his previous imaging studies were brought for me to give a second opinion in a clinical session at the hospital where I work. This is the first MRI of the left shoulder obtained in an external service 1 month after the onset of pain. These fluid-sensitive sequences show that there is a destructive lesion of the body of the scapula with an aggressive appearance, leading to infiltration and discontinuity of the cortical bone, indicated by the arrows, and edema of the adjacent soft tissues. If I were in charge of reporting this MRI myself, I would recommend a biopsy as the next step in the investigation. And this is the CT scan obtained at almost the same time. Once again, a lytic lesion with a lucent matrix is observed in the body of the scapula with multiple areas of cortical violation indicated by the yellow arrows. Retrospectively, we can note that despite the presence of bone destruction, There is cortical thickening rather than thinning. In addition to a solid periosteal reaction, to which points the green arrows. At that point, I said to my oncologist colleagues, you already have 2 biopsies showing no neoplasia, so it is most likely not a tumor. And the child is improving on non-steroidal anti-inflammatory drugs. And looking retrospectively, it looks like osteitis to me instead of infection or a tumor. So why not perform a whole body MRI to look for additional areas of osteitis that could favor an autoinflammatory bone disease instead of a third biopsy? It is a shot in the dark. I know the scapula is not a frequent site of involvement in this setting, and I've never seen involvement of this bone in chronic recurrent multifocal osteomyelitis before, let alone as the presentation site. But what do we have to lose? And thank God I was right. We see that in addition to the inflammation in the scapula, the whole body MRI showed additional foci of osteitis on the left, in the medial femoral condyle, and in the proximal tibial epiphysis, as well as in the hindfoot. Thus, with the correct investigation, we went from an almost certain bone tumor to a typical CRMO imaging picture. If you're still in doubt, on the lower row, we can see the follow-up MRI performed 2 weeks ago, 9 months after the first one. Observe the marked involution of the edematous changes and the quite impressive recomposition of the cortical integrity of the scapula. Only subtle residual bone marrow edema remains, marked by the yellow asterisks, with complete resolution of the cortical findings and the soft tissue component. Sorry. Therefore, this patient was diagnosed as having an unusual pseudotumoral presentation of non-bacterial osteitis, better known as chronic recurrent multifocal osteomyelitis, or CRMO. CRMO is a broad topic that could easily take up an entire symposium of its own, but in a nutshell, it is an idiopathic inflammatory bone disease, typically affecting children between late childhood and early adolescence, that is underdiagnosed but increasingly recognized. It usually appears as multifocal areas of non-pyogenic osteitis and bone erosions that typically involve the metaphysis of the long bones, classically in the lower limbs. And as it was shown in this case, whole body MRI is paramount for the diagnosis and follow-up in this setting. Later in the disease course, there is bone expansion with sclerosis, hyperostosis, and periosteal reaction. And as there is no systemic involvement and laboratory tests and biopsies are non-diagnostic, CRMO is a diagnosis of exclusion. Therefore, biopsies should be avoided, if possible, when imaging findings are typical. So it comes as no surprise that the diagnosis is often retrospective and late, with a median of 2 years, usually after several medical consultations with different doctors of different specialties. Because biopsies are non-diagnostic, there is a trend in favor of replacing them with whole body MRI in typical cases, thus shortening the time to diagnosis. Nonetheless, biopsies may be unavoidable when CRMO presents as a unifocal and/or aggressive bone lesion on imaging, especially on atypical sites, such as in this case, since the scapula is involved in only 5 to 7% of all cases of CRMO. And biopsies usually lead to diagnostic delay, which was minimal in this case because the possibility of CRMO was raised early and whole body MRI was performed timely. There are some skeletal sites that, when affected in CRMO, are prone to mimic bone tumors. For example, the thin tubular bones, such as the fibulae and the metatarsals, may present lamellated diaphyseal periosteal reaction, diaphyseal, not metaphyseal, that emulates bone tumors. In addition, when the medial thirds of the clavicle are involved, findings such as bone destruction and expansion, aggressive appearing periosteal reaction, and extensive edema are often found, but this is a classical site of involvement in CRMO. Although this is usually not a problem for the seasoned radiologist acquainted with pediatric MSK imaging, it may be challenging for those who don't see pediatric studies quite often. In this slide, we can see a classic example of a lamellated periosteal reaction in the diaphysis of the second metatarsal bone, in addition to bone expansion and marked edema of the bone marrow and adjacent soft tissues. Fortunately, these findings were present in the context of multifocal osteitis, which made their interpretation easier. But if they were present in isolation, a bone tumor would have to be considered in the differential diagnosis. And finally, an example of involvement of the medial third of the clavicle, which, as I said, is very typical in CRMO. In this case, while the MRI shows extensive edema of the bone marrow and soft tissues adjacent to the right clavicle, which show post-contrast enhancement, the CT images show aggressive bone destruction of the head of this bone with osteolysis, cortical discontinuity, and interrupted periosteal reaction, typically without involvement of the sternoclavicular joint. So what are the take-home messages of this case? First, the radiologist is usually the first doctor to raise the possibility of CRMO during the investigation, in addition to indicating how to confirm it. That means whole body MRI. We can formulate a robust presumptive diagnosis of CRMO when typical imaging findings are present. However, one must keep in mind that this is a recently described disease with an increasing learning curve all over the world, and that atypical presentations may be challenging even for the seasoned radiologist. Therefore, we must maintain a high index of suspicion for bone lesions resembling bacterial osteomyelitis or tumors with inconclusive biopsies in age-appropriate patients, namely older children and young adolescents. Thus, in a setting of possible CRMO, we, the MSK radiologists, must guide the investigation since we are the specialists. And it's not infrequent that the doctor in charge is unaware of the mere existence of CRMO. So it is up to us to raise awareness of the key role of whole body MRI in this setting. Thank you very much for your attention.
Thank you, Sergio. So I will open the Q&A session with a question to Pilar. Is there a chance of recurrence or a recurrence rate in the literature for Grisell's syndrome? And should we be concerned that these children may have another episode of subluxation?
Yes, certainly. The higher the grade, basically, the more likely there could be a recurrence eventually, because the ligaments may be damaged, especially if aggressive treatment is not put in place. So eventually, yeah, type 3 or type 4 may have a higher degree of recurrence if they're not properly treated, right, surgically. So, yeah.
Thank you. To Paulo, what is the prognosis for individuals with juvenile hyaline fibromatosis?
Yes, unfortunately, there's no specific treatment for these patients, and the plastic surgeon can have a pivotal role because most of their complaint is about their face, their appearance, and the support is with with painkillers, basically, but it's a genetic condition with no treatment for the time being.
Thank you, Paulo. And now from Eduardo Brown to Sergio, what is your whole body MRI protocol for CRMO and spondyloarthritis?
Hi, Brown. There is a very recent article from our colleagues from São Paulo about protocols of whole body MRI in children. Whenever it's possible, I try to perform a stir or a Dixon, depending on the equipment. A stir acquisition, a T1 acquisition, and diffusion acquisition. However, if we are looking specifically for inflammatory conditions like this one, and the patient is unable to cooperate, to bear a longer time of examination, simply acquire fluid-sensitive images, either Dixon, either stir. These are the most important, as we are looking for bone marrow, essentially for a bone marrow edema. In the coronal and in the sagittal planes.
Okay, and so what coil do you use to get whole body images? I think it's to you, Sergio.
I don't. It depends on the, once again, on the equipment on which I am working. At the Children's Hospital, we have a dedicated equipment that has the coils which fit one to another and cover the whole region of interest. However, in non-dedicated machining and non-dedicated equipment, we have to improvise a little. We have to obtain each station with the available coil, the most adequate coil, in order to later on to compose the images into a single one.
Now for Paulo, this is from Leah Gendler. Is there a regional demographic propensity for this condition? She never heard of it, me neither, and it's very interesting, she said.
Basically, it's a very rare condition with 100 cases reported in literature, but more extensively, I would say that when you work in a community in which there's a high rate of consanguinity, all these strange conditions must be taken into account because it's a recessive genes, and especially when the patient comes from a community in which the marriages are between cousins or in the same family. The question raised in the diagnostic differential diagnosis is this a genetic condition? This is depends on the area. I don't think there's an ethnicity, a specific ethnicity, and there was for this condition, for example, discovered 10 different mutations. So it's probably a social problem, also a social problem.
Now from G to Sergio, how long are your average scan time? How often do you add T1 to exclude red marrow hyperplasia?
Hi, G. Once again, it depends on the equipment and on which I'm working. At the Children's Hospital, we have very short times of acquisition. So usually is not a problem, especially if we choose to perform a more compact, a shorter version of the protocol. However, in another service, private service, where I work, and we are able to perform whole body MRI. It takes, in average, 45 minutes to acquire a complete protocol, as we don't have the specific coils, the specific equipment. The equipment is not so new, so contemporary as the one that I have in the at the Children's Hospital. And the second question, how often do I add T1? Essentially, when there is suspicion of infiltration of bone marrow. We have a lot of patients with cancer and hematopoietic disease at the hospital. So when this is the case, yes, we include T1 weighted images to evaluate the red marrow. Otherwise, if the suspicion is related to inflammatory disease, we stick with the fluid sensitive sequences only most of the time. It's important to have in mind that the whole body MRI in children is intended to be a short examination, not too long as we perform, for example, in an adult patient with myeloma, for example.
And she's asking, if you see sites of abnormality, do you ever switch coil and obtain dedicated smaller FOV images? In US, there is concern that they are billed in full and makes it difficult to get follow-up imaging.
We usually do not have this kind of concern here in Brazil. Yes, sometimes we, after the whole examination of the whole body is completed, we perform a localized scans of a given area of concern. And usually we are not concerned with being billed for it. Nor in the public service, nor neither in the private sector.
Thank you. I don't see any more questions here. So thank you. Thank Paulo, Pilar, Leah, and Sergio, and Hilary, of course. Thank you all for joining us today, and see you in the next session. It's in December, I'm not sure, but I will let you all know on social media. Bye.